Good afternoon. First, I would like to thank the scientific committee for the first cardiovascular disease and movement conference here in Dubai, and thanks Dr. Joeria for her hard work to establish and organize this meeting and for her invitation. So the second lecture for today in prevention is about cardio-oncology. So I am basically a heart failure specialist, but I have interest in cardio-oncology because oncology treatment impacted or has one of its cardiotoxicities, and major cardiotoxicity is cardiomyopathy. So basically, if we talk at the beginning about cancer in general, and the statistics on cancer, and then we'll go over to what is cardiotoxicity and how are we going to prevent this. First, female breast cancer is still the leading cause of the incidence of cancers in a global cancer statistic that was published in 2021 over that. And the second cancer is lung cancer. When it comes to mortality, lung cancer is the predominant mortal or lethal cancer with 18% compared to breast cancer, which is 6.9% of all total cancer mortality. When it comes to just cancer in females, the incidence is higher, and the breast cancer is the leading cause of cancer incidence, with around 24 to 25% of all cancers are due to breast cancer. And when it comes to mortality, because it is, though lung cancer is more mortal, but because of the highest incidence of breast cancer and their survivors, so it is still the higher mortality among all cancers. So we have different cancers that are just pertinent to females. The most important one is breast cancer. It accounts around 15% of all cancer. Basically, 99% of all breast cancers are women, only 1% are related to men, and it's the most common female cancer. And with the progress and of chemotherapy, radiation therapy, and other cancer therapies, the survival rate of breast cancer is high, can reach up to 100% in stage 1, and in stage 3, up to 98% 5-year survival. And this is due to chemotherapy and radiation therapy and surgical therapy. Only survival rate is 25% at 5 years is for stage 4 cancer. So, and we know that most cancers are presenting with either localized or regional disease. Only 6% of breast cancer have distant metastases. And not only that, but the prevalence of survivals of breast cancer after curing these patients is high, and more patients are living and they are survivors of breast cancer. But when it comes to breast cancer itself, what are the risk factors? There are many risk factors to develop breast cancer, but what are the main risk factors for me as a cardiologist and as a cardio-oncologist? The higher the age, the higher the incidence of breast cancer. But at the same time, the higher the age, the higher the cardiovascular comorbidities. And at the same time, 1/4 of breast cancers are in premenopausal women. These are young patient population, and I am afraid on the long term, I don't want these cancer patients who are cured to develop cardiovascular disease in the future. So there are different breast cancer treatment, but actually when it comes to stage 4, it's only palliative with chemotherapy, but stage 1 to 3, neoadjuvant surgery and adjuvant chemotherapy in addition to radiation therapy when needed. So chemotherapy, surgery, and radiation. When it comes to chemotherapy, the most common chemotherapies that are being used are anthracyclines, taxanes, platinums, and cyclophosphamide. Mainly anthracyclines and others, they all have cardiovascular complication. And the treatment for sure depends on the stage at presentation and if they have any tumor overexpression like HER2, estrogen receptor, or progesterone receptor. But if we look at the cancer treatment in breast cancer therapy, we can see that radiation, chemotherapies, they all have some cardiovascular toxicities. When it comes to radiation of the left chest, we worry about long-term cardiovascular toxicity, which are coronary heart disease, valvular heart disease, in addition to cardiomyopathies. When it comes to chemotherapy, the most common cancers treatments that are used are anthracyclines and trastuzumab, which is the HER2 receptor antagonist. And both, they have a high incidence of LV dysfunction and heart failure in this population. Other cancer treatment may cause hypertension, arrhythmias, arterial and venous thrombosis. The second cancer is endometrial cancer. It's the most common gynecological malignancy, and most of these patients, they present in the early stages. When it's in the early stages, there is no chemotherapy, just only local radiation therapy. When it comes to advanced stages, then the treatment that has been prescribed is either doxorubicin and anthracycline, cisplatin, or immune checkpoint inhibitors. And all these can cause either LV dysfunction or myocarditis that indirectly can lead to LV dysfunction. Ovarian cancer, too, is important, and with the treatment with chemotherapy, their prognosis is better, and their 5-year survival can reach up to 80 to 95% in stage 1 and 2. And when it comes to advanced stages, their prognosis is poor. And when it comes to treatment, they are given chemotherapies that may lead to cardiovascular toxicity. One important is bevacizumab, which is vascular endothelial growth factor inhibitors, and this can cause hypertension, arterial thrombosis, and sometimes it can cause ACS, acute coronary syndrome, and myocardial infarction, as well as cardiomyopathies. The last cancer that I will discuss in my first type of presentation is cervical cancer. Also, the mean age is around 50. Most of the patients are presented, or 45% are presented early on. Their survival is, 5-year survival is high. When they present in the advanced stages, their survival really is poor. But also, if treatment is to be given to these patients in advanced stages, they need some treatment like cisplatin, paclitaxel, and bevacizumab. All these can have cardiovascular toxicities, mostly not heart failure, but others like arterial thrombosis and hypertension. So this is just a review of all the systemic cancer treatment in gynecological malignancies and the potential cardiovascular side effects. All can cause some toxicity, whether hypertension, coronary artery disease, acute coronary syndrome, arrhythmias, or cardiomyopathies. One important, and I told you before, chemotherapy that is used in breast cancers is anthracyclines, and the second is trastuzumab, which is the HER2 receptor antagonist. And both, they have a high incidence to develop LV dysfunction. And in anthracyclines, the higher the dose, it's important to know the dose, the higher the dose, the higher the incidence of LV dysfunction. Second thing, if the patient is already treated with anthracycline first, and now it's going to have the second protocol with monoclonal antibodies like trastuzumab, the incidence is high. So a baseline treatment with anthracycline is a risk factor to develop cardiotoxicity in this population. So we have noticed that cancer treatment in a woman, whether breast cancer and other related cancers, has increased survival of this population. So we have more and more cancer survivors, and the prevalence of cancer survivors is increasing with time. And this population of patients with that survived cancer and survived the chemotherapy, they are at increased risk to develop cardiovascular toxicities, especially with anthracycline. The late cardiovascular toxicity can occur 5 to 10 years post-treatment. And at the same time, if we just look at PubMed and search cancer and cardiovascular toxicities, we can see that with time we have more and more publications on cancer-related cardiotoxicities. The most common are vascular disease, cardiomyopathies, as well as hypertension. And recently, the International Cardio-Oncology Society has defined what are the cardiotoxicities. It's not only, as we know before, it's cardiac dysfunction and heart failure, but myocarditis from immune checkpoint inhibitors and immunotherapy, vascular toxicities, whether venous or arterial venous thrombosis or arterial embolization and thrombosis, hypertension, arrhythmias, and QT prolongation that can lead to arrhythmias and sudden cardiac death. And it depends on the cancer, on the chemotherapy itself. So each chemotherapy has a different mechanism to lead to its cardiotoxicity. When it comes to LV dysfunction, these mechanisms can be direct damage to the myocytes, like in anthracycline, or indirect damage, like in immune checkpoint inhibitors causing myocarditis, in vascular endothelial growth factors causing ischemia, or others causing arrhythmia and systemic hypertension. So chemotherapy and cardiotoxicity is really more complicated than expected. We have different agents that have different toxicities, each with a different mode of action. Cardiovascular toxicity onset differs, short and long term. So it's important not only to baseline and screen these patients, but also to look after these patients when they are cured from cancer. Some, they have a reversible cause, reversible toxicity, and some they have irreversible toxicity, like in anthracycline prototype. And the knowledge of oncology drugs and cardiovascular toxicity is important to determine our low threshold to diagnose these patients early on. So I consider that patients who are cancer patients who are receiving chemotherapy or radiotherapy to the chest, they are at increased risk, and it is actually a risk factor for heart failure and other cardiovascular diseases. And this is why there is a new era in cardiology. It's called cardio-oncology, and it's a new specialty by itself. Why? Because cardio-oncology as a specialty, it not only risk stratifies patients as a service itself. Early diagnosis is important, prevention and treatment are important. So these are the 4 key elements for a cardio-oncology service or cardio-oncologist. They have to early risk stratify these patients, early diagnose if we have cardiotoxicity, prevent and treat. Because we don't want the cured cancer patient of today to be the heart failure patient of tomorrow. And the main goal of the cardio-oncologists are to avoid the possibility that cancer therapy could induce cardiac disease, and that by preventing it or early diagnosing it. But at the same time, we have more and more patients at the elderly patients who are developing cancer, and these patients may have cardiovascular disease at baseline. So we don't want these patients, because of their pre-existent cardiac disease, not to receive the adequate cancer therapy, and this will affect their survival too. So this is important too. And the decision usually, it's a close collaboration between, and a strong collaboration between the cardiologist as well as the oncologist, because the decision depends on whether it is a palliative treatment or it's a curative neo or adjuvant therapy. Because if it's palliative therapy and the prognosis is poor, we are not going to worry about late cardiovascular toxicity of these patients, because they will die before cardiovascular toxicity. But if the prognosis is good, then we are worried about late cardiovascular toxicity. So us as physicians, we should know about the cardiovascular side effects of chemotherapy and radiation. We need to identify patients at risk, determine their risk factors. We should take preventive measures, know the expected time of cardiotoxicity, and we should always have a low threshold for complications and diagnosis. There are several publications has been published recently about cardio-oncology and cardiotoxicities, but recently in August 2022, this was the first guidelines on cardio-oncology published by European Society of Cardiology, though it's a 133 pages of guidelines, but because we have different chemotherapeutic agents with different cardiotoxicities and with different algorithms to prevent and diagnose these patients. There are different new definitions of cardiotoxicity. But what is important, that what we used to call as chemotherapy-induced cardiotoxicity, it's now called CTRCD, or cardiotoxicity-related cardiac dysfunction. There are other definitions like ICI, myocarditis, immune checkpoint, vascular toxicity, hypertension, and arrhythmias. When it comes to LV dysfunction or chemotherapy-related cardiac dysfunction, they divide it into symptomatic and asymptomatic. Symptomatic, we all know that the patient developed heart failure and we need to treat him or her, but what is important is the asymptomatic, and it's divided into an asymptomatic drop in EF to more than 10%, 10 points, or the mild cases, which is heart ejection fraction is preserved. And this is very important because oncologists, they always call us before giving the chemotherapy, what is the ejection fraction? But ejection fraction is not only tells us about cardiotoxicity, because these patients may develop subclinical cardiotoxicity, like when we measure other elements in echocardiography, like global longitudinal strain. If there is a decrease by 15%, then this is positive for later developing cardiac dysfunction, and or if we have a new rise in biomarkers like troponin and NT-proBNP, also is significant for that. One word about radiotherapy, we know it's less complications, but what is important, radiation therapy to the left chest frequently augments the cardiotoxic effects of systemic cancer therapy. So any patient with left chest radiation and now is coming for another chemotherapy, he is at a high risk or moderate to high risk to develop cardiotoxicity. This is why in these guidelines, they emphasized on baseline cardiovascular risk stratification. And this includes, we should ask about the previous cardiovascular history. If we have cardiac imaging like echocardiography, cardiac biomarkers are important. Age is important, especially in anthracycline. The higher the age, the higher the risk. Cardiovascular risk factors are important to ask about and to screen them for that. We should know if they have any previous cancer therapy or radiation therapy, because this puts them at a higher risk, or what is the treatment for these patients. If it's anthracycline, we have to monitor the dose, and we have to really worry about LV dysfunction and know when is the onset of this, depending on the chemotherapy as well as lifestyle modification. The second important thing is it's not only baseline risk stratification, but we have to monitor these patients, especially the patient at moderate to high risk. And always we have to risk stratify them during cancer therapy. And in agents like anthracycline who can develop cardiotoxicity later on, 5 to 10 years later on, we need to keep long-term follow-up of these patients, because I see in my practice a lot of patients who were cured from cancer, breast cancer, coming again after 5 to 10 years with heart failure and a very low ejection fraction. So they recommended that cardiovascular toxicity risk stratification is important as a class 1 indication, but what other important thing is close discussion with the patient and with the oncologist about that, and to refer patient to cardiology when they are at a high risk for cardiotoxicity. EKG is important on every patient who is going to receive a drug with potential cardiotoxicity, as well as biomarkers as baseline. It's important, and during monitoring, especially in anthracycline and HER2 receptor. Why they are important? Because there are smaller studies in NT-proBNP as well as in troponin. If there is a persistent positive troponin signifying myocyte death in patients receiving anthracycline, these patients are higher risk, they develop cardiomyopathy. And if we start on these patients ACE inhibitors, the chance to develop or the risk to develop cardiomyopathy was significantly reduced. We usually, oncologists use MUCA scan before chemotherapy, but actually it is not considered except if TE and cardiac MRI are not available. The gold standard is echocardiography, transthoracic echocardiography for baseline risk stratification, because it doesn't tell us about ejection fraction, about global longitudinal strain, about RV, about filling pressures, about pulmonary artery pressure, and about diastolic dysfunction, because all these and valvular disease can be risk factors to develop cardiotoxicity. Another important thing is ejection fraction. It's really an insensitive tool. We finished? Time. Can we continue? Ejection fraction is an insensitive tool because when ejection fraction drops, then the patient has, when ejection fraction drops, then the patient already developed cardiotoxicity, and most of these patients, they don't, if we treat them, they don't come back to their normal ejection fraction. I will not go over them. I already mentioned about anthracycline and the higher dose. There are different protocols with anthracycline and with HER2 receptor, especially in high-risk patients. We have to take biomarkers and echocardiography very more frequently. There are some small studies on primary prevention that state that ACE inhibitors, beta blockers, statin, they may improve in primary prevention, but when patient develops secondary prevention like positive biomarkers or a drop in EF, then the patient has to be treated as a class 2 indication by guidelines and is also by ACC guidelines. And early diagnosis is important because if we diagnose them late on, then the chance to recovery is low. When they develop heart failure, we have to treat them with the 4 pillars. Always long surveillance is important. And I will end here that cardiologists as well as GPs and oncologists, they have to be aware of the cardiotoxicities, and they should have a low threshold to refer patients early on for early diagnosis and for early treatment. Thank you.